Mr. Chairman, dear colleagues, I begin to my presentation with two apparent disadvantages. I am the last speaker, the last day of the meeting, and also the topic is, is a nightmare, an unwanted topic. But I will try to do my best to give some information about this nightmare. It should be kept in mind always, and also it should be treated in a really very planned and with appropriate measures. Stenting is commonly used in urologic practice, and you see the main indications to ensure an adequate drainage, relief of ureteral obstruction, catheterization after iatrogenic injuries, and also to identify and protect ureters during certain surgeries. We have different types of stents, and we daily used in different parts of the world. And the most important part is to place the catheter in an appropriate way, to check it and to know that it is in place. This is the most important part in the beginning. And otherwise, we may have some difficulties, some problems from the beginning. We may, if we don't know it, if we don't notice it, then the problem will go further and we will see it later. And also, it's also controversial about the duration of the stenting, and these are the sentences that I derived from some publications in the literature, and the authors did write that patients with longer durations, more than 15 days, the other wrote that 1 day ureteral catheter placement after ureteroscopy. In another study, it was written that the stents were kept inside the body for a mean period of 28 days, and in the other one, the stent was routinely placed for 3 weeks. Different time periods, and there is no clear-cut indication or consensus about that. Coming to forgotten JJ stent is a difficult problem, and if left untreated, these retained stents may result in significant morbidity as well as mortality. Why? Poor compliance of the patient, and also failure of the physician to adequately counsel the patient. Also, the forgotten stent will have some related complications further to us. Migration may be anticipated, knot formation, fragmentation, extensive encrustation, stone formation, and recurrent infections will be our problems to face, to deal with. Beginning with encrustation, we know that may occur in both infected and sterile urine. Elevated urinary pH favors the precipitation of magnesium and calcium as well as struvite and hydroxylapatite. As a result, urine crystallizes on the surface of the biomaterial. And as you see here, in different parts of this stent, we may have encrustation with different sizes of the stones occurred. How about the risk factors for encrustation and stone formation? As you see here, patients with a history of stone disease and also patients with a recurrent stone formation anamnesis will be the ones that should be closely followed with respect to this problem. How about the causative factors? As you see here, the degree of the encrustation is dependent on the dwelling time period. El-Faki and his co-workers were able to show that encrustation increased from 9.2% at less than 6 weeks to around 77% if the indwelling time is over 12 weeks. Chronic recurrent stone formers, metabolic predisposition to stone disease, congenital anomalies, malignant obstruction, and pregnancy are the other factors to increase the rate of encrustation over the stent itself. Following the encrustation, we will have some other complications. As you see here, we may see large stone burden, recurrent infections, hematuria, obstruction, and renal failure can come after this problem. These are the pictures that we may face after getting out the stents from the place after encrustation. The other problem is, following the encrustation also, fragmentation can be anticipated during long-term follow-up. Loss of tensile strength, which is due to the hardening and degeneration of the stent polymer, is the main factor. Silicone was found to be least prone to encrustation, followed by polyurethane, Silytech, Percoflex, and hydrogel-coated polyurethane. Fragmentations of polyurethane stents are 4 times as frequent as the silicone ones. You see here some pictures from the fragmented stents in place. Coming to the management of this nightmare or difficult situation, multimodality endourologic approaches are often needed because of encrustations, and the associated stone burden may involve the bladder, ureter, and kidney. While single or multiple endourological sessions are commonly applied, open surgical removal of the incrustated stents is a rare option. Few studies so far have introduced algorithms for the management of these cases. However, we know that using a combination of shockwave lithotripsy, PCNL, cystolithotripsy, and ureteroscopy with lithotripsy will give us a stone-free rate of ranging between 75 to 100%. Open surgery, again, I may say that it will be rarely needed. What are the factors affecting the method of choice, method of access? There is no consensus on which method is the best for managing forgotten stents in a practical and efficient manner. A true preoperative imaging evaluation is cornerstone to decide about the management alternative. Site of encrustation is important. Associated stone burden is important. Function of the affected kidney is also very important. In any case, no significant force should be used to remove the stent. In case of no encrustation visible on the KUB, cystoscopic removal using a grasping forceps under local anesthesia, under also fluoroscopic guidance, will be the first approach. However, we should be very gentle traction on the stent that will be applied. If patient complains of pain, and if the stent does not uncoil, the procedure should be abandoned. An important precaution during the procedure is to avoid using excess force to get the stent out. How about the use of shockwave lithotripsy? This will be the initial treatment in case of minimal encrustation. However, due to the extensive stone burden in the majority of the cases, this modality seems to have a very limited role, indicated only for localized, low-volume encrustations in kidneys with reasonably good function to allow spontaneous clearance of the fragments. How about cystolithotripsy? With the help of pneumatic lithotripsy, this approach is the method of choice for stents demonstrating minimal encrustation in the lower part, in the bladder area of the stent. Following disintegration, stent will be gently pulled under fluoroscopic guidance. Coming to ureteroscopy, if ureteric portion of the stent is encrustated, a safety guide wire is passed along the retained stent, and ureteroscopy can be performed under anesthesia. Calcifications over the stent can be fragmented via either using pneumatic lithotripsy or by using laser energy. After fragmentation, the stent again will be gently removed with the help of grasping forceps under guidance. Following removal of the stent, it's mandatory to do a retrograde ureterogram and check ureteroscopy to rule out a possible injury during the procedure. Coming to the PCNL, this modality will be performed mainly for the stone-covered proximal end of the stent. It seems reasonable to go first to the distal end, manage the stone burden, including removal of the lower curl, and facilitate PNL with placing a ureteral access catheter. After placing the ureteral catheter in place, renal pelvic calyceal system will be visualized, and percutaneous access will be established by a lower calyceal or middle calyceal puncture by using the contemporary classical way. The stent, after fragmentation, the stent again will be gently removed under fluoroscopic guidance through the tract. We may have some selected cases, and in these cases, nephrectomy may be done for non-salvageable with non-functioning kidneys. Nephrostomy or placement of second stent is done in case of pyelonephritis and sepsis, the infectious problems. And in some cases, to insert a second stent adjacent to the encrusted one is possible due to the dilated nature of the involved ureter. Going through the literature, as you see here, Singh and his co-workers described multiple accesses and approaches, including open surgery to treat these stents. Barbarola and his co-workers reported endourologic treatment of 4 patients with severely encrusted ureteral stent with large stone burden. All patients require 2 to 6 endourologic approaches performed at 1 or multiple sessions and to achieve a stone and stent-free status. Also, the authors concluded that PNL and ureteroscopy are often necessary for treating the difficult cases. Again, Dr. Bukadwanam and his co-workers did report that one-stage removal of 12 encrustated retained ureteral stents in 10 patients, 11 cases were matched by ureteroscopy alone. In 1 patient, the stone was treated through percutaneous approach. And they concluded that retained and severely encrustated stents can be removed in 1 sitting with minimal morbidity and short hospital stay. But the most important part, apart from treating these stents, not to encounter them, to prevent ourselves to face these nightmares. And for the prevention, we may say that although endourological management of these stents achieves success in majority of the cases with minimal complications, the best treatment that remains is the prevention of this complication. The treating physician should be very selective in placing the stents, and the patient must be tracked very closely by documenting insertion and removal of the stents. It has been reported that the period between 2 to 4 months can be considered optimal. However, patients with recurrent incrustations on stents should have them changed earlier than the others. Poor compliance of the patients represents the main cause for a forgotten stent. Education of the patients and explanation of the problems that a forgotten stent can cause may convince to comply. All patients should be counseled with respect to the complications of long-term use and advised when their stents should be changed. For patients requiring stents beyond for a certain period, they should be kept on a prophylactic antibiotic and have their stents frequently changed. It is also important to maintain proper record of all stents inserted and keep a track of their due date of removal. And some authors on this aspect have proposed a computerized tracking program for removal of the stents. By providing more information, patients could share their responsibility with their clinicians regarding tracking of their stents, having patients play an active role in their treatment by getting them to take the responsibility, to share the responsibility for tracking of their stent may be an effective means to reduce or prevent stent-related problems. Stent card register system has been applied and reported in the literature, but this system did not appear to play any role in terms of preventing stent loss because it was infrequently reviewed and difficult to update. By using a computerized database accessible by physicians, a universal database of all stents inserted could be created to track them. And the computerized system still forms a fail-safe mechanism by automatically sending reminders to follow up overdue or presumed forgotten stents. Hamad told about their study. It's a really nice study, and they reviewed a computerized stent tracking system which automatically alerted patients and clinicians before the stents became overdue for removal. And they concluded it lowered the incidence of overdue stents from 12.5% to 1.2% during a year period. That's very, very important for us and for the patients. How about the other measures? An information booklet including essential information detailing the date and site of the stent insertion, the indications, the planned date for removal and complications from the stents will be beneficial. A copy of the information could also be sent to the general practitioner so they can also keep a record and establish computerized reminders to check the stents have been removed when the patients come to them. So to conclude, we may say that encrustation and stone formation in forgotten stents often lead to life-threatening complications and pose a challenging management task for the treating surgeons. The use of various combinations of endourologic techniques can achieve effective and safe stent and stone treatment with minimal morbidity and short hospital stay. Imaging and assessment of the degree of stone burden is important before making any attempt to remove these stents. Urologists should bear in mind the presence of severe incrustations when they have to deal with a forgotten stent. Treatment should be tailored to the volume of the incrustation and associated stone burden. Although endourological management of these stents achieves success in the majority of the cases, the best treatment that remains is the prevention of this complication. Maintenance of efficient logbook under direct supervision of treating surgeon and proper patient counseling is required to prevent this complication. Thank you very much for your attention.